Hello, my name is Brian Rojas and today is July 3rd, 2022. I am presenting Unit 2 Case Connection Studies. This is case study number 2. In a nutshell, this is a pediatric patient involving a 16-year-old female who has been diagnosed with a deficiency of muscle glycogen phosphorylase. In this scenario, the patient and her family are asking questions regarding the condition, and I am answering the questions as their provider. They first express that they don't understand the condition and how is muscle glycogen normally used during exercise. So to start off, what is muscle glycogen? Glycogen is the principal storage carbohydrate found in the body. When glycogen originates in skeletal muscle, it is called muscle glycogen. Muscle glycogen's sole purpose is to provide the muscle cell a source of metabolic fuel during times of fasting. Muscle glycogen is an essential fuel for intense exercise, whether the exercise is of an anaerobic or aerobic nature. I would inform the patient that based on her blood work or muscle biopsy, that she is diagnosed with a muscle glycogen storage disease called McArdle's disease. People with McArdle's disease are unable to access the glucose bound within glycogen, and as a result are unable to obtain energy from the glucose stored in her muscle glycogen, resulting in the fatigue and muscle aches that she has been feeling. This is all due to a deficiency of a muscle enzyme called muscle glycogen phosphorylase. Muscle glycogen phosphorylase is an enzyme that catalyzes the rate-limiting step in glycogenolysis. What does this mean exactly? It means that glycogen phosphorylase catalyzes a chemical reaction between glycogen and a phosphate group. This reaction results in the removal of a glucose molecule plus one high-energy phosphate group, creating glucose 1-phosphate. Their second question is if she is still able to take long walks with her friends. Due to the research and studies on patients with McArdle's disease, not only is this acceptable, but it is also highly recommended. I would ensure that her muscle glycogen is merely one out of the many sources of fuel for her skeletal muscles. She will receive energy from glucose straight out of her diet, liver, and gluconeogenesis, as well as the existence of alternate energy sources such as the oxidation of fatty acids and ketone bodies. I will also reassure the patient that people living with McArdle's often take advantage of a second wind phenomenon. This usually occurs 10 minutes after the start of gentle exercise. This can be attributed to a combination of extra blood flow and the ability of the body to find alternative sources of fuel. The family and patient also ask that due to this deficiency, will she still need to get up at night to eat and maintain her blood glucose? I would explain that while she is sleeping, her body will be in a fasted state. In this state, it would primarily be the duty of the liver to maintain proper blood sugar levels across the entire body using hepatic or liver glycogen. Although she has a deficiency in the enzyme that breaks down glycogen to glucose, in this case, only glycogen in her muscles are affected. She still has functioning glycogen phosphorylase in her liver cells. I would suggest that she sleep throughout the night. However, if she wakes up hungry, there is no harm in grabbing a snack. Lastly, the family asked about excessive lactate being produced during intense anaerobic exercise. I would cite that according to Meti et al., that there is no significant difference in blood lactate levels between healthy individuals, highly trained athletes, and people with glycogen phosphorylase deficiency. I would also ensure that lactate is an important source for gluconeogenesis in the liver. In her case, her body will be very reliant on glucose produced from this pathway as a source of energy. Finally, I would recommend routine physical examinations and diet checks, as well as establishing a physical strength and conditioning program under the supervision of a specialist. Thank you, and please let me know if you have any questions in the discussion section. Bye. Hello. For my second Unit 2 Case Connection Studies, I have chosen to answer case study number 4. In this situation, we have a pediatric case involving a 2-month-old female presenting with jittery spells and lethargy in a few hours after eating. A physical was conducted, and an enlarged liver was discovered after percussion of the right chest and abdomen. Blood lab results show hypoglycemia. Epinephrine is administered, and there is no increase in blood sugar. However, there is an increase in blood lactate. Blood glucose levels only seem to increase after breastfeeding. However, proper blood glucose levels cannot be maintained during periods of fasting. Last to note, The patient has not been given anything else to eat other than breast milk since birth. There are many factors to consider in the diagnosis of this patient. Since the baby has only been fed breast milk for its entire life, we can safely eliminate any intolerances to any other types of sugar. Hereditary fructose intolerance is caused by a deficiency of the enzyme aldolase B. Aldolase B is responsible for the metabolism of fructose, breaking fructose 1-phosphate into glyceraldehyde and dihydroxytone phosphate. Those with fructose intolerance do develop hypoglycemia and abdominal symptoms. High levels of unprocessed fructose build up in the liver, leading to hepatomegaly. However, in our patient's case, breast milk is comprised of glucose and galactose. The baby has not been given any fructose yet, and therefore its current condition cannot be caused by a deficiency of aldolase B. Galactosemia is a disorder involving galactose metabolism, caused by a deficiency of galactose 1-phosphate uridyl transferase, also known as GALT. People with galactosemia are unable to produce energy from galactose found in milk. This is a life-threatening condition in newborns that appears within a few days of birth. High levels of unprocessed galactose build up in the liver, also leading to hepatomegaly. In this case, the chances of our patient having galactosemia is unlikely. If we remember from our clinical findings, the patient's blood glucose levels are only maintained when she is breastfeeding. This implies that she is capable of metabolizing breast milk. Plus, she is several months old now and would have presented with life-threatening issues at a younger age. Another diagnosis to consider is glucose-6-phosphate dehydrogenase deficiency. Glucose-6-phosphate dehydrogenase, also known as G6PD, is a key regulatory enzyme in the pentose phosphate pathway. Like the enzyme's name suggests, a hydrogen atom is removed from glucose-6-phosphate and added onto NADP to create NADPH. G6PD is an essential in maintaining a proper reducing environment in cells, especially in red blood cells. G6PD is the most common enzomyopathy in the world. People with G6PD deficiency suffer from hemolysis when the blood is exposed to certain foods, most commonly fava beans, drugs, infections, or stress. Patients present with jaundice, which is a yellow coloring of the skin and eyes. Our patient does not appear to be suffering from glucose-6-phosphate dehydrogenase deficiency. Blood work did not come back positive for hemolysis, nor is her skin jaundiced. The next possible diagnosis to consider is that the patient has a possible glycogen storage disease. There are multiple types of disorders involving the metabolism of glycogen. Glycogen storage disease, type 1, also known as Van Gogh disease, is a deficiency in the enzyme glucose-6-phosphatase. This enzyme is essential in the final step of glycogenolysis and gluconeogenesis. Glucose-6-phosphatase hydrolyzes the separation of glucose-6-phosphate into a phosphate group and glucose. This reaction allows glucose to be free to leave the liver and enter the bloodstream. This enzyme is crucial in providing glucose to the whole body during periods of fasting. Due to the buildup of glycogen molecules that cannot be converted to glucose and released, hepatomegaly is a hallmark finding in those with glycogen storage disease type 1. Signs and symptoms typically occur around the age of 4 months. Around this age, babies start to sleep throughout the night and do not eat as frequently as newborns. Affected babies will have low blood sugar that may lead to seizures. Affected babies are also found to have high levels of lactate and fatty acids, as well as uric acids in the blood. These conditions seem to match up with what our patient is presenting with. The administration of epinephrine with no increase in blood glucose levels confirms that our patient cannot maintain a catabolic pathway. Elevated levels of epinephrine promotes glycogenolysis in the liver. No increase in blood glucose means no glucose is being released from the breakdown of glycogen in the liver. Elevated levels of epinephrine also promote lipolysis as well as lactate-producing glycolytic reactions in skeletal muscles. The patient's elevated blood lactate levels after the shot of epi can be attributed to her body seeking alternative fuel sources. Lactate from nearly all cells can enter the Cori cycle, which is converted into pyruvate and eventually into glucose in the liver through gluconeogenesis. Unfortunately, deficiencies in glucose 6-phosphatase will prevent this newly created glucose from entering the bloodstream, further contributing to the buildup of glucose 6-phosphate, glycogen, and lactate in the blood. Due to these clinical findings, it's safe to conclude that the patient's inability to sustain blood glucose levels during a fasted state is caused by glycogen storage disease, choice C. Thank you once again. If you have any questions, please ask me in the discussion section. Bye.